Professor Pankaj sir. So I am very much delighted to introduce him as a speaker. He is an excellent teacher. Actually, you will be realizing after his lecture that and the topic he has chosen is a very complex topic. Uptake and distribution of inhalation anesthetic agent. Actually, it's a difficult topic in anesthesia. It's very difficult to understand. He will make you to understand very easily. So this is how the uptake of the inhalation anesthetic from the alveoli and how it reaches the brain, how it's being distributed, everything he will be highlighting. It's a very complex topic. Please concentrate on his lecture. Thank you.
Thank you very much, sir, for the kind introduction. And thank you, Dr. Edward, for giving me this opportunity. It's a pleasure to be here. A very unique way of introducing the first year PGs who have recently joined. You're very lucky, as the rest of the speakers have already mentioned. Now, you're going to become an anesthetist. So your prime goal is to provide proper anesthesia, right? That's why this topic is so important, that how do you give proper anesthesia to the patient, understanding how these agents are taken up, how do they produce anesthesia. So the process of anesthesia, or to produce a proper anesthetic depth, is dependent upon the minimal alveolar concentration which is required to produce a proper anesthetic depth. Now, how do we achieve this? When you deliver or you turn on the dial, you're going to send the gas into the alveoli, and because of alveolar ventilation, either when you're back ventilating or the patient is breathing spontaneously, those vapors from the vaporizer are going to reach the lung. So the molecules are in the vapor stage. Now when they have to go from a gas medium to a liquid medium, that is the blood, there has to be a coefficient. So that is what is called the blood gas partition coefficient. So it depends upon the solubility of the vapors, how much they dissolve into the blood. After that, because of the cardiac output, these molecules are circulated throughout the body, and the most important organ where they need to produce the anesthetic depth is the brain. So they have to transgress from liquid medium to a tissue, or let's say a solid medium. So again, there will be a partition coefficient on which these vapors will depend upon to act and to go across into that tissue. So that's called the liquid, or that's called the tissue blood partition coefficients. So these are the two coefficients you must keep it in mind, that from one phase of matter, the vapors are going into a different state of matter. Now we talked about MAC, and I told you that MAC is important as a guide for producing adequate depth of anesthesia. So what is MAC? MAC means that when you give a noxious stimulus to any patient, there should be an absence of a motor movement, that the patient doesn't move. And if it occurs in 50% of the patient, that is defined as a minimal alveolar concentration required to produce suppression of motor movement or purposeful movement to a noxious stimulus. So what does it tell us? It tells us two things. One is that the depth of anesthesia is to be maintained, and secondly, because you use many of inhalational agents like desflurane, like sevoflurane, like isoflurane, and they all require different MAC. So to determine or compare their potency, you need to know what is MAC. So when we say 1 MAC, it is a generalized nomenclature used for all inhalational anesthetic agents, because the concentration will differ, but MAC should be constant, right? That determines the potency and depth of anesthesia. Now look at these graphs, if you see these graphs. So these are called MAC graphs, And there are three components which determine these concentration response curves. Now, what do you mean by concentration? The concentration of an anesthetic or an inhalational agent required to produce a particular response. And that response is the motor movement or a purposeful movement. How can you suppress that movement? What concentration would be required to suppress that movement in a patient so that the depth of anesthesia is maintained? So you have three parts. One is the potency, which is the x-axis. The other one is the slope. This is relatively a vertical line. It is not tilting towards the right. And the third one is the maximal efficacy. And what do we want to achieve? We want to achieve a maximal efficacy of immobility, right? On this side, we have the number of patients. So as I told you, it is in 50% of the patients that immobility should be achieved. At what concentration of that would determine the MAC? Now, look at these lines. These are relatively vertical lines. Vertical line means that there is hardly any change in the concentration to achieve this endpoint. That is, I'm not having any change in this concentration across all the patients, across all of us, to produce suppression of mobility with a particular concentration, which means we're almost straight line. There is hardly any deviation in the concentration. That means these concentrations are relatively constant across population. So if I say 1 MAC, I will be able to produce anesthesia properly in all patients across the population. So the percentage of variability is very less, which is only about 10 to 15% probability. So that's the beauty about inhalational agents. And that is why in your monitors, you look at the MAC value to say that you have properly anesthetized the patient. How is it uptaken? Now we come to the real topic. If I could understand this background, then now it will be easy for you to grasp what I'm going to tell you now. The uptake and equilibration is important. So first thing is, you will switch on the dial of a vaporizer. The vapors will be produced from the lungs with the help of alveolar ventilation. These vapors reach the alveoli. And the concentration which is achieved in the alveoli is termed as the fractional alveolar concentration, or FA. The concentration which you have set on the dial of the vaporizer is Fi, or the inspired concentration of the anesthetic vapor, right? Now comes the diffusion across the blood-gas partition. So the molecules now have to diffuse across from the alveoli into the blood. So that is where it is coming into the liquid phase. And with the help of cardiac output, it is now going to go into the brain, right? And there also we have the tissue-blood partition coefficient. So from blood, it has to go across into the brain to produce a desired effect. So what are we trying to achieve? We want to achieve equilibration of these vapors which we have said in all the three medium, that is in the vapor, in the gas form, in the liquid, and in the tissue. Once this equilibration has achieved, it is called a steady state, and that is where the patient is properly anesthetized. Why am I saying so? The problem is, if you don't anesthetize your patients properly, and if they're aware during surgery, there's going to be a lot of trauma which is going to be associated with the patient for the rest of the life. It is called post-traumatic stress disorders. They have very different kind of sleeps, hallucinations, and other issues happen. So giving proper anesthesia is what is your duty, and how to deliver this is the most important part. So 1 MAC, if there is an equilibration which is achieved here, and if I am able to see 1 MAC in my monitor, that means I have achieved 1 MAC concentration in the brain. So it is, the monitors are telling you what is the depth, which is not so with intravenous agents. You only presume that you are going to give this, You have to have surrogate markers like BIS, bispectral index, to know the depth of anesthesia, but they do not correlate very well, where the gas monitors gives you precise concentrations which are achieved for maintaining a depth of anesthesia. Now, what are the factors which are going to influence the alveolar concentration? So the factors which are going to be affecting the inhaled concentration are two or three. We will come to them later. The second is, what are the factors which are going to increase the rise in alveolar tension? And third is, what are the factors which are going to increase the uptake or determine the uptake by the blood? So these are the three factors which define what is going to be the uptake of the inhalational agents. We have not come to the distribution, so we'll first talk about the uptake of a distribution system. So let's talk about these factors. What factors can affect the inhaled tension? Whatever you have set on the vaporizer, what factors can affect before it is delivered to the alveoli? So this is a nitrous oxide and oxygen. These are the fresh gas flow, and I have kept a halothane concentration of 1% onto the vaporizer. So it will go through this will be the FI, that is the set inspired concentration. Now you are going to have an artificial environment which has to be created to deliver this FI to the alveoli, and these are the anesthesia breathing circuits. So the peculiarity about this anesthesia breathing circuit is that some of the molecules may also get adhered to the surface. So they may have rubber gas solubility, or even PVC or plastic gas solubility, or they may not be delivered in the amount which you have set here, like insulin. Some of it gets adhered to the drip set. Similarly, some vapors which you have set here are stuck here and they are not developed to the alveoli. So the second part can be the volume of the circuit. If the dead space is very high, this dead space has to equilibrate to this part before the same concentration can be delivered to the alveoli. Third can be, where do you give the fresh gas flow? If your fresh gas flow is proximal, it will take a longer time for equilibration, but if it is distal, it may take lesser time, as in the case of Bain circuit. So the inspired gas concentration, if you remember, is set by percentage. That you have set 1%, 2%, 3%. That is how you set the vaporizer. But the effect of the gas which is produced in the brain is by the partial pressures, not by the concentrations. Concentration gradient is established for intravenous agents, but for inhaled agents, it's the partial pressure gradient which is most important. Therefore, you need to convert the inspiratory concentration into the partial pressures to understand how these agents are going to be taken up. So for that, it's a simple formula. Pi of a gas is equal to fractional inspired gas concentration into the atmospheric pressure. So if you look at oxygen, 21% divided by 100 into the atmospheric pressure, it is going to be 760. So the partial pressure of oxygen is 157. So you can similarly substitute for your inhalational agents as well. So let's come to the second factor now. The agents have reached here, the molecules have reached in the alveoli. Now what are the factors which are going to determine the rise in alveolar tension? So there are two methods by which it happens. One is a concentration gradient, the other is the alveolar ventilation. So this is basically determined by the molecular movements across the pressure gradient between the alveolus and the blood. So this will determine, the concentration will determine how much of it goes into the blood, and the alveolar ventilation will determine how much of it reaches the alveoli. Right? So these are the two important factors which will determine the concentration effect and the alveolar ventilation. So the alveolar ventilation is determined by the second gas effect. Now how do these things happen? let us have a look at it. So first we will talk about the concentration effect, then we'll talk about the second gas effect. Please put your mobiles down, listen to what I am talking. That's more important than recording to what I am talking about. So these are the molecules of nitrogen, you have oxygen, you have nitrous oxide, and you have the inhaled vapors here, let's say it's halothane or sevoflurane. So the blood is here, the nitrogen freely goes across, and nitrous oxide is much more soluble, or 20 times more soluble than the nitrogen. And that is why when most of the nitrous oxide is lost into the alveoli, what will happen? Alveoli was filled up with nitrous oxide and oxygen. So the alveoli will shrink in size. So the size of the alveoli becomes small because the gas which was there in it, most of it has diffused into the blood. So there is a reduction in the size of the alveoli. How do the alveoli retain back their normal size? That's by the means of enhanced alveolar ventilation. So by enhanced alveolar ventilation, it takes in more of the gases from the upper airways that is dependent upon your fresh gas flow, and it retains back its size. And that is how it happens by augmented ventilation. So what is important here is to know what has come into the alveoli, how much of the fresh gas portion has now occupied the volume of the alveoli to restore its normal volume. So to understand this, if we were giving 1% of sevoflurane, 19% of oxygen, 80% of nitrous oxide. So this is the whole volume of the alveoli. Now, with the loss of nitrous oxide, which was 50%, this 80% would have come down to 40%. The oxygen still remains the same, right? Because nitrous oxide was 20 times more soluble. So the most of the alveolar volume is lost because nitrous oxide has gone away. You have not changed 1%. 1% still remains because it has the blood gas partition coefficient. It is still not diffused across into the blood. Now, 40 divided by 60 into 100, you will find that the nitrous oxide concentration, which was actually 80%, has now become 67.7% in that reduced alveolar volume. What happens to the oxygen? Oxygen concentration goes up. It goes up to 31.7 because the volume is reduced, but the fraction still remains the same. What happens to sevoflurane vapor? If you look at the sevoflurane vapor, I have divided 1 by 60, it is 1.7. So automatically, because of augmented alveolar ventilation, the sevoflurane concentration has gone up, the oxygen concentration also has gone up. Now let's talk about what is this second gas effect. So this is the concentration effect which I have described in brief. Now during next inspiration, the patient is going to take in another 80% of nitrous oxide, 19% of oxygen, and 1% of the gas. This is what is going to happen in the next inspiration. So what will happen to the desired concentrations? So if you supplement this restored, this 40% which was lost has been restored here by this inspiration. So if you look at the concentrations here, this is what is going to happen. And that is the reason, because there is loss of nitrous oxide, it enhances the concentration of the sevoflurane. That is what is termed as the second gas effect. So 80% into 40, this is 32% has been lost, and your final concentration of the sevoflurane has gone up to 1.4%, which was initially 1% because of nitrous oxide, and this is called the second gas effect, right? So concentration effect is to a reduced volume of the alveoli, but once the alveolar volume is restored, then it is the second gas effect, which still makes a difference because the concentration of sevoflurane has gone up to 1.4%. Now the effect of ventilation, suppose we are giving nitrous oxide, this is an assumption. The tidal volume is fixed, FRC is fixed, alveolar ventilation is fixed, and the time of and the respiratory rate is fixed. what happens to this nitrous oxide concentration? With the first breath of 500 ml in 2005 liters, because FRC was 2000 plus 500 ml of what has been added, it comes to about 20% of nitrous oxide. So in the second breath, if I add a 400 ml which is going to go in or which is there, you'll find that there is 36% increase. It's not gone to 40%. So there is an exponential increase. It's not a linear increase of nitrous oxide which is happening, right? This is what you need to keep it in mind. It's not that it will just keep doubling. There is an exponential increase, and if you look at these calculations, you'll understand that at the end of 1 minute, 86% of concentration will be achieved in the alveoli of nitrous oxide if you're giving 100% nitrous oxide. It's not reached 100% at all here at all, right? It has reached 86% 1 minute because the patient is breathing at 10 breaths per minute. So it may take 6 time constants to actually achieve 96%. So we come to something called as a time constant. So this is something important which you need to understand. If you don't understand this, the whole lesson about inhalational agents would be totally incomplete. So what is this time constant? There are 3 things which are constant. One is 63% of equilibrium, that what you are delivering, the inspired concentration, the alveolar concentration will be only 63%. That will be defined as the one time constant. If the alveolar concentration reaches 86 of the inspired, it is 2 time constants, and when it reaches 95% of the equilibrium, it is 3 time constants. So what does these time constants mean? This is basically volume divided by the flow. So the volume can be of the circuit as well as of the lungs. So in the circuit is the circuit capacity, and the flow would be the fresh gas flow, while in lungs it is the FRC or the functional residual capacity, and the flow will be the alveolar ventilation. But the third thing which is important and which you need to understand is the solubility of the gas towards the tissues. So time constant would be volume divided by flow into solubility of the agent, which will give you what is the exact time constant required. So these time constants are important to understand that what you are setting on the vaporizer, how much of the concentration in what time the alveolar concentration would reach 63%, 86% and 95% of what has been set on the vaporizer. That's what is the importance. So let's see how the time constant can change. This is one exercise. This is the circuit volume of 7 liters. If I take the corrugated hose, reservoir bag and CO2 absorber, and the FRC of an individual is 2 liters. So the time constant would be the total volume, and if I set up a fresh gas flow of 6 liters per minute, the time constant here would be 1.5 minutes. That is one time constant, right? Now let's say that we use a brain circuit. Instead of this corrugated circuit, I reduce the circuit volume. And if I reduce the circuit volume to 1 liter, then you will find that this total volume is 3 liters, my time constant is 0.5 minutes or 30 seconds. Therefore, if you understand these concepts, you will now understand why we pre-oxygenate for 3 minutes. So in 3 minutes, if I am getting 6 liters of oxygen with a circuit volume of 6 liters per minute, or the circuit volume is 6 liters, to achieve 95%, that is 3 time constant, I will take 3 minutes. Right? Is that clear? So that is how you determine at what time the alveolar concentration has been achieved, where the surgeon can start the surgery. If you don't understand, you will be most likely creating a patient who is aware for a surgical procedure. Now, we talked about the alveolus, and we need to talk about the brain, because the final effect is at the brain. So this is the tissue solubility which you need to know, or the tissue gas coefficient which you need to know. So this is about the capacity which is taken by 100 grams, and the blood flow which is taken in 100 grams. So if you look at the tissue brain blood partition coefficient, this is what has been defined for different agents. So for one time constant, if you look at each gram of gray matter gets about 1 ml of blood per minute. Therefore, the brain time constant should be equal to the solubility of the anesthetic agent in minutes. Right? Because it's getting such a high blood supply, so each gram of the brain gets 1 ml per minute. Therefore, the solubility of the anesthetic agent would determine the brain time constant. So this is what you achieve in 63%. That is 63% would be achieved of 1.9 at 1.7, 1.6, 1.3 and 1.1. But if you have to achieve 95% equilibrium to what is being delivered by your vaporizer, you have to multiply that by 3. And therefore, to achieve a good effect of sevoflurane, if you are going to take, it will take about 5 minutes before you can anesthetize the patient properly, and you should not start surgery before 5 to 7 minutes have elapsed before you have achieved this time constant of 90% kind of your concentrations there. So how can you induce or use your inhalational agent as induction agent, just like your IV agents? So let me show you a video here. This circuit has been primed, right? Once I prime this circuit up, the patient has taken one vital capacity breath and the second vital capacity breath, and you will find the patient is induced. Right? What has happened? The patient has been induced in less than 20 seconds without even producing any sort of a cardiovascular compromise. So the reason is that the entire circuit which was there was initially primed. So all the dead space had the same concentration of an inhalational agent which was set on the vaporizer. So my volume was reduced from 7 liters to only 2 liters because rest of is the FRC. And that FRC can be taken up by, can be filled up with higher flows which the patient is matching, and you will be able to achieve induction within 22 seconds. It is as smooth as a thiopentone. It can produce less hemodynamic stability, and you can use it for daycare surgery. So this is the way you can use inhalational agents, provided you understand what are time constants, how the uptake happens. Now let's come to the last part of the uptake by the blood. Uptake of the blood from the alveoli into the blood is determined by these Lobie's formula, which F defines the inhalational concentration, delta Bg defines the blood gas partition coefficient, Q is the cardiac output, and T is the time. So this is what is initially a graph which is given to all of us. This is called as FA-FI curve. Dr. Edward, can I take 5 more minutes? So this is termed as the FA-FI curve. FA, as I told you, is the fractional concentration of the alveoli, of the inhalational agent in the alveoli. This is an inspired concentration. Now, what is this curve? This is time here, this is FA-FI. So, at 8 minutes, you find there is a bend, right? So, from 0 to about 0.75, concentration is achieved in the alveoli. So, the FI was 1, but FA is about 0.75. It has taken about 8 minutes and it has reached the alveoli at this particular point. Now, why is it not going up? It is not going up because there is something called as a need which is produced by the cardiac output. So now what is happening is, whatever concentration has reached the alveoli are going into the blood, and therefore the concentration in the alveoli is slowly falling or plateauing. But this alveolar plateau is still not a straight line. It is slightly going up. It is not straight. The reason why it is going up is the venous return. Had there been no venous return, this should have been a straight line. Now, why is this venous return contributing to it? Because there is some molecule still in the venous circulation which are coming back to the lungs, which have not been distributed to the various organs. So that's why this keeps going up, and that is contributed by the venous return. So this part of the curve, the rise in the alveolar tension is because of alveolar ventilation or your positive pressure ventilation which you give. This knee is produced by the cardiac output, and this plateau which is uprising is produced by the venous return. So we come to a very important aspect here. All these agents, desflurane, sevoflurane, isoflurane, halothane, have different heights. So the plateau is different, and this plateau is different because of blood gas solubility. So if you see if the blood gas solubility is low, the plateau is high. So if the vapor dissolves in the blood, it will not exert any partial pressure. The vapor which is not dissolving in the blood is only going to exert an anesthetic action, because that's the partial pressure which is required to be achieved in the brain. So if it is dissolved, most of it is wasted, and that is what is the blood gas solubility. So most of the SIVO as well as the desflurane molecules do not dissolve in the blood, therefore their blood gas solubility is low. So what do you mean by this blood gas solubility? This is the concentration of the vapor in the blood versus the concentration in the gas, right? Because we are giving it as concentration onto the vaporizer. So if it is 50%, 50% of it dissolves, that means the blood gas solubility is 0.25. But if the gas is insoluble, it doesn't dissolve much in the blood and it remains in the gaseous form. Therefore, the alveolar concentration would almost equilibrate to the brain concentration at a very higher pace. But if the solubility is high, lot of the molecules are wasted because they get dissolved in the blood, and very few molecules are there which are not dissolved, which are not insoluble, which can produce an effect. So for isoflurane, if you say the blood gas solubility is 1.36, it means the concentration of the isoflurane in the blood should be 1.36 times the one in alveoli before it can create an effect. So that is what is the blood gas coefficient, right? So this much amount of concentration of the isoflurane in blood, which should be more than in the alveoli, which will produce equilibration of partial pressures. Am I clear? So the concentration of the isoflurane has to be much higher in the blood, almost 1.36 times that is in the alveoli, to produce equilibration of your partial pressures for it to exert an effect. So that is what the blood gas coefficient tells you. The second part is the alveolar deficit. We talked about these plateaus, right? We were talking about blood gas solubility, but look at the alveolar deficit which is happening. Alveolar deficit means it is not FA by FI, it is FI by FA. So if you look at the FI by FA, it is the alveolar tension which is required to control the plateau height, and that is where the overpressure ratio is required, the ratio between inspired concentration and the alveolar concentration to get a desired alveolar tension. So that is what is called an FIFA, which is determined by the overpressure effect. So that much amount of concentration has to be produced into the alveoli, that partial pressure has to be produced in the alveoli to get you a better induction or get the patient at a faster depth into anesthesia. So if you have to calculate this, this is how the depths are there for different alveoli of different agents, and if the respiration is kept constant, the FIFA is about 0.55, and MAC would be the what you will have to multiply to get it. So if it is 1 is the inspired concentration, the alveolar concentration which you have achieved is 0.55 here, divide into MAC, 3.8 should be for the sevoflurane. So that is what should be your aim. Keep at least 3.8% sevoflurane concentration to achieve an effect in 5 minutes. Before that, if you don't achieve this, then your patient is not going to be properly anesthetized. The problem is, all of you give muscle relaxant, you are actually paralyzing the patient, and it's a awake patient who is paralyzed, who is not able to give you that movement, and you think everything is good. So that's where the major problem is occurring, and that's why these understandings are extremely important. Distribution, it's through the mouth. You find that through ventilation it comes to the lungs, and these conduits determine how the agent is going to be distributed. So these are the vessel-rich group, and which of it is the brain. But there are certain other group areas where, like in muscle and fat, where the conduits are small, but the reservoirs are large. So if the reservoirs are large, then you will have problems. So let's see if a larger reservoir, what will happen if it is a highly soluble anesthetic. So if it is a highly soluble anesthetic, you will find that these reservoirs grow in volume, and therefore they take a longer time for induction, and they take also a longer time to recover back. Right? If it is a slow soluble agent, or the blood gas solubility is low, then these volumes are contracted, and therefore the induction is much faster and the recovery also is much faster. So I will just stop here. Thank you very much for giving me this extra time.
Thank you, sir. It's really a tough topic, presented very nicely by excellent teacher, Dr. Pankaj Kudra. People are very fortunate to hear this topic from Dr. Pankaj. Thank you, sir.
And I request Dr. Phillipson sir and Dr. Rajani sir to honor the chairpersons.